surrounding countries, and one of them are from the clinical center Rebro from Zagreb, and they would like to present us some of their cases and to ask for expert opinion. So I invite Dr. Halužan to show his presentation and his cases from his center.
Thank you very much. I would like to thank the organizer for the opportunity to present some of our cases here in front of the distinguished professors and the audience. One of our cases is a male that was hospitalized in the clinic for infectious diseases for sepsis after acute prostatitis. He had lumbar pain, intermittent febrility, chills, and fatigue of 2 months in duration. They did an MRI which presented spondylodiscitis between L1 and L2 vertebrae and psoas muscle abscess. Then they did an CT which showed the suprarenal aortic aneurysm with the celiac trunk, superior mesenteric arteries, and renal arteries that were involved within the aneurysm. The patient were transferred to our institution. He was put on intravenous antibiotics, and after some time he was transferred to our institution. We made a new CT which showed increase of diameter of the aneurysm for 1 centimeter in 3 weeks' time, and he had bigger pain in his lumbar area. This is the MRI, and this is the CT. And our question is, what would you do?
Thanks. I know very well this type of pathology because you treat, I think, almost 5 cases that are septic aneurysm with spondylolithitis and infection of the thoracic vertebra. And this is a big problem because the patient present a really big sepsis, a really septic patient. At the beginning, use homograft. But you have a very, very poor result with homograft. Either in abdominal position, either in thoracoabdominal position, because the homograft, in my experience, lasts some time, but after the disrupt without reason, and the patient dies. So you stop to use homograft, and now I use Dacron with silver Dacron and antibiotics to replace this. And I replace this situation like a typical type 4 aneurysm. For example, this case I will replace it without left heart bypass to decrease the contamination of the blood around the world, and I do a reconstruction with silver prosthesis and reimplantation with a carrier patch of the vessel, probably with the left renal artery separated and distal anastomosis. I do with prosthesis.
Okay, thank you.
Any other comments, Professor Davidovic? You maybe have a comment.
We have the same opinion. My choice also would be the usage of silver-coated acre graft and omentoplasty.
Any other comments?
Yes.
Our Professor Petrovic used thoracophrenal apparata, medial visceral rotation, a bypass from distal thoracic aorta to celiac trunk and superior mesenteric artery with Dacron grafts. When he opened the aneurysm, he found the rupture of the posterior wall of the aneurysm. He made the debridement, reconstruction with cryopreserved aortic homograft, and the reimplantation of renal arteries with Dacron silver graft. We didn't have small caliber cryopreserved aortic graft, and then we used the Dacron silver graft instead. Okay, that was a couple of years ago, and then the patient in 2017, was admitted to a local hospital with the acute occlusion of renal arteries. They tried unsuccessful thrombolysis and endovascular treatment. And he was sent to our hospital a couple of months later with aneurysmal dilatation at the distal anastomosis of the previously implanted cryopreserved homograft and abdominal and lumbar pain. And that's the CT about 4 years later. What do you do now?
Professor Chiesa already told you don't put the homograft. Why did you put the homograft?
Now we know why we don't put it.
I told you that with homograft we have
Yeah.
usually.
Okay.
Always surprise with homograft.
Yeah. Okay. What would you do?
Replacement with tube graft.
Okay.
No other possibility.
Okay. We did another possibility. We put an EVAR inside. Yeah. We put an EVAR. As we didn't have any renals, we had a lot of place to put the EVAR, so we put it just below the graft that was for the branching of the celiac trunk and the superior mesenterial artery. And the patient is now a year and a half in follow-up and is doing well.
But a lot of time is ahead
Yeah.
for this.
Okay, we can now show another. This is the follow-up CT of the patient. Okay, this is another patient that came in 2015 with Stanford A dissection. He was admitted to our cardiac surgery department, and it was done by reconstruction of ascendant aorta with supracoronary ducrum graft. The cardiac surgeons use sandwich technique, Teflon felts, and 2-component glue at the distal end. So in 2018, he came to our institution with abdominal and lumbar pain. The MSCT showed dissection that spreads through the whole aorta up to the iliac arteries, the rupture of the right common iliac artery, aneurysm, which was 11 centimeters in diameter. This right iliac artery was supplied by true lumen, and he had an aneurysm of 6 centimeters in diameter in his left common iliac artery, which was supplied by false lumen. These are the pictures. So these are another pictures. What do you do now? Okay, as you said, this was 1 month after my vascular surgery exam, and I was on call. So as a kid, I loved to play video games. So I decided to do an endovascular repair. So when we put the pigtail catheters, we have seen 2 different lumens. One on the right side, it's the true lumen, and on the left, it was the false lumen. So we called Igor for advice. He told us to try it. So we have done the endovascular repair with 2 endurant iliac extensions, 2 extensions from true lumen to the right external iliac artery, and 2 extensions from the false lumen to the left external iliac arteries. And this is the postoperative CT.
But patient was not fit for open repair, or
he was fit for open repair, but he had 2 large aneurysm in the lower pelvis, and I thought that this would be the better strategy for him. But I called the professor just in case to be standby if I mess something up to help me. So it's the post-operatively, the patient had some buttock claudication, but 6 months later, he had a walking distance of almost 500 meters. Now it will be 9 months after the procedure.
The most important thing that he's arrived.
Yeah, it's a controversial case, so we wanted to discuss it. When we got the case, we called Igor, and he gave us good advices. So.
Yes, please.
We treat similar case just a couple of weeks ago with the same situation with dissection and thoracoabdominal dilatation and aneurysm of the iliac arteries. And we decided to treat it surgically just in the infrarenal part with the orthobifemoral bypass in order not to prevent possible subsequent endovascular treatment for the thoracoabdominal aorta. If you start with an endo approach, probably subsequent endo treatment could be a little bit more difficult because you have two different endoprotheses in two different lumens. So how can you manage with that? Have you got a plan for that?
If he will need another surgery. Yeah.
For the upper part.
Yeah, we will do, because one or the each leg has its own circulation. If he needs another surgery, we will just do a crossover bypass on each side. One must.
No, I mean up in the thoracic part and thoracoabdominal part.
We will do the open procedure.
Thank you.
It will be conversion after TIVR.
I told the most important thing, that patients survive, but you and Igor should think about future treatment option.
Yeah. we in this case we also had a few options, so one of them worked. So this is the follow-up CT 6 months after the procedure, and the patient is doing fine now. And the third case is one of Professor Petronich's case. It was a young male that was in 2011. He was in a hospital for infectious disease for the pain between the scapula, heavy bleeding, and leukocytosis and large CRP. He was given antibiotics, and 3 weeks later he reported to the same hospital with hemoptysis, heavy bleeding, and increased inflammation factor, leukocyte of 25,000 and CRP of almost 400. CT showed large mediastinal hematoma as a result of thoracic aorta rupture. He was going to another hospital which performed TIVR, and after TIVR he had some minor endoliquid stop, and he was discharged after 10 days follow-up, and his follow-up was uneventful. And you see a resorbed hematoma after the initial procedure. He was rehospitalized in about 9 months later with high temperature, chills and shivering, leukocytosis, and CRP of 230. They did an CT which showed extravasation of the contrast in the mediastinum along the aorta and the front edge of the stent graft with mediastinal hematoma. He was transferred to our institution, and when he was transferred, he had a rupture of mediastinal hematoma in the esophageal lumen. He had one hematemesis, and after that it stopped. So this is the stent graft. This is the CT of aortic rupture. This is the CT of mediastinal hematoma, and this is the air bubbles. I think this is an easy for you.
I think correct treatment, and now we necessity to wait and see what happened.
Okay.
Because it's very similar to the case I demonstrated with the movie.
Yeah. So we did an operation, resection of thoracic aorta, stent graft extraction, and reconstruction by cryopreserved homograft and ligation of left subclavian artery. This was done in hypothermic arrest. We usually prefer clamp and saw technique. The professor prefers the clamp and saw technique. We did the deep hypothermic arrest. We prepared the cryopreserved homograft. We have extracted the stent graft, and we have put the anastomosis just distal to the carotid artery left. And this is the post-operative MRI. He's now in 7-year follow-up after the cryopreserved homograft. And this is the control.
Sorry, the fistula with the esophagus?
We the professor checked out the esophagus. He didn't find the place of the rupture, so the patient was put on parenteral feeding for 3 weeks, and then we did another esophagoscopy, and we didn't find the rupture. So after 3 weeks, he started it spontaneous. Yes.
This is one to ask Professor Chiesa. Professor Vidic, yes, please.
May I have only one comment regarding TIVAR at patients with mycotic aneurysms? In my opinion, TIVAR should not be considered as a first treatment option at patients with any mycotic aneurysms because very high incidence of reinfection. Namely, I believe that open repair is still gold standard for definitive treatment of all mycotic aneurysms.
Thank you, Professor. In your experience, Professor Chiesa, did you preserve the esophagus in cases, and how many do you, in cases with the graft infection?
This is a really big and terrible problem, what you do with the esophagus. Because when you have a fistula, you need to treat always the esophagus. And we try different possibility. You do, if you had a small hole in the esophagus, to reconstruct direct the esophagus, I use intercostal muscle to cover the esophagus. I use momentum from the down till to circle completely the esophagus. But this is always a big problem. And I do this surgery together with some thoracic surgeon, general thoracic surgeon who treat the esophagus. And our idea in the time with more experience is if it's not a very, very small lesion of the esophagus, the best treatment is to remove the esophagus and to do an operation 3 months, 4 months later with substitution in another way, subcutaneous, what you want with stomach, with colon, with other, because the esophagus fistula is very, very dangerous there.
Yeah, thank you. Thank you very much. Thank you, Dr. Halajan. Thank you very much.
Thank you.
I have now pleasure to invite Dr. Ivan Marian.